Thank you. I want to thank Karen in particular for inviting me to speak here. There's a little bit of nepotism in this talk because we both worked at the University of Washington together, and I came back to Seattle 13 years later after she occupied my office at the university. There was no more room, so I went to Virginia Mason, which is just about 2 blocks up the road from there. I have no disclosures, other than the fact that in the last 7 years since I moved to Virginia Mason, I have not had to do an operation on a patient with a severe acute pancreatitis or infected pancreatic necrosis. So why am I talking on this particular topic? And it's because really percutaneous drainage for infected pancreatic necrosis really started here in Seattle. I'm going to give you some background about that. We're going to talk about the indications and the rationale, the percutaneous approach, the timing, the technique, the clinical outcomes, having spanned almost 28 years, and the role of how percutaneous drainage is integral to improving endoscopic drainage and avoiding operation altogether. The indications historically were to control sepsis, to get that under control, so that we could meet that golden hour to preferably operate on patients, wait a month or so, okay, so to delay operation. But what the data is showing us now with all this therapy that Karen just showed is it's really to treat sepsis completely and to avoid operation altogether. And I'm going to review the largest series that support that. So the logic is, first, percutaneous approach, even in a grossly septic patient with multiple organ failure, it's the least invasive approach in a critically ill patient. And it's the first step, other than antibiotics, to mitigate sepsis and to give us a chance to postpone necrosectomy if it's really necessary. And one of my colleagues is going to talk about VARDs and how a percutaneous catheter is really kind of essential as to the first step of a VARDs approach because it's the guide to get there. And so that percutaneous drain, when appropriately placed, is key to VARDs. And then at the end, I'm going to talk to you about what we're doing at Virginia Mason of how percutaneous approach is used in combination with endoscopic drainage, so-called dual modality drainage. The indications really are failure to improve on medical therapy. All these large studies show that a large number of patients resolve their symptoms even without drainage, okay? So we're talking about in the patients that are deteriorating in one way or another, okay? The onset or the progressive multiple organ failure measured a variety of different ways. SIRS, leukocytosis fees, or a rising CRP has shown to be predictive of at least ultimate drainage. And as I said, the first step up in the MIS approach. The timing, as you heard Karen say, is to postpone as long as possible. There are papers that have chosen 18 days as a break point. Then there are studies like our own where the longer the better, even out to 2 months before draining patients. And we know that early drainage before there's walled off pancreatic necrosis is associated with increased mortality. So we temporize whatever we can do. So I'll show some pictures like Karen did. Here's the first week after severe acute pancreatitis. This is not wampum yet. This is just peri-pancreatic collections and necrosis. And here it is a month later. This is still not a good collection to drain. It's multiloculated. It's not going to lend itself well. But if the patient were to deteriorate, we would put a drain in that patient. But we would still want to wait a little bit longer if possible. The ideal route for placing a percutaneous drain, and the majority of the literature supports the anterior pararenal or retroperitoneal approach as illustrated in the lower 2 arrows, but sometimes particularly associated with central pancreatic necrosis when there's a complete pancreatic duct blowout, you get a central collection. It's not very accessible or not very amenable to an anterior approach, but you can go transgastric straight through the stomach with a percutaneous drain, or you can slip between the colon and the stomach into a cavity, the so-called anterior direct approach. So this patient, assuming that these 2 large collections in the anterior perirenal spaces do not communicate with the midline anterior approach, this patient might get 3 catheters. But we would typically start with draining the left-sided first because it may communicate with everything, and then seeing how the patient does clinically, and then if they are not responding or they're deteriorating, access the other sites as well. This just shows the one on your left is not accessible through the anterior perirenal space on the left. You can see there's no plane really to get there between the kidney and the spleen. And this patient was drained with an anterior approach. You just see the pigtail catheter in there, okay? So Karen actually participated in this survey. It was published recently in HPB. It addressed the issue of the delay thing, and this survey was distributed to all the big pancreatic type people around the world. And what the opinion showed was, you can see that if you had clinical signs of gas on a CT scan, the majority of the practitioners would still wait over time. If you can wait as long as possible, that's great, okay? And if they didn't have signs of gas, they would wait even longer, okay? So, but that just shows you that the majority of people want to wait beyond 20 days before any consideration of drainage for the reasons we already discussed. So in this particular study from France, the authors chose an 18-day period. That's close to that 20-day period. And they showed that if you had a percutaneous drain beyond 18 days, that the mortality was substantially less compared to those that were drained earlier. Now you have to read something into that. What does that say? There may be a tremendous selection bias here, right? There are some patients that are going down the tubes with sepsis despite all medical support therapy, and so that triggers, and so by natural selection, they just have worse disease. And in fact, in this study, they showed that mortality was also related to another of other predictors, but the severity of disease at the presentation we know also predicts mortality. So you have to think that a little bit. But nevertheless, if you look there at those gray bars, what that says is that those patients that had longer wait had an overall clinical success with percutaneous drainage alone. Not VARDs, not open or endoscopic, but just with drainage alone. Look out there, beyond 25 days, 13 out of 15 patients clinically resolved. Okay, so let's talk a little bit about that technique. Ultrasound or CT guided, at least in the United States, that's done by an interventional radiologist almost always. Be interested to hear what you're doing in Canada. Okay, preferentially a retroperitoneal approach. If you do go anterior through the stomach, probably is the safest way. If you're gonna go retroperitoneal, be thinking about subsequent VARDs. If that patient doesn't respond, you want that catheter in an area to avoid organs and major blood vessels so that you can follow the catheter in and do a VARDS procedure. Here's just a quick video. This patient is in this is the anterior approach. Patient is in the CT scanner. The interventional radiologist sticks a catheter in there by ultrasound, is doing a minimal aspiration, and then is going to put a guide wire into it. The patient goes back into the CT scanner. You know the guide wire is in the right spot. Now he's using the Seldinger technique, putting the catheter into the place, goes back into the CT scanner to prove that the catheter is well positioned, that there's not a bunch of leakage or air anyplace else. Here's an example of a patient. She's rolled up left side down because the VARDS approach is going to approach from the right, but that's the ideal sort of catheter position going into the anterior perirenal space. And one of my colleagues will talk about that. Catheter care, most interventional radiologists will place a 10 to 12 French initially, and then sequentially upsize no sooner than 72 hours, and then to go as big as 30 French. It's basically a chest tube. And if you have thick gunk in there and chunks, then you're going to need to get a big catheter. If you get a lot of chunks initially, some people will put more than one catheter initially, but our approach is to just put one catheter. Then there's the issue of how do you maintain the catheter? Should you be doing lavage? How much lavage, et cetera? Our approach, as originally described by Dr. Freeney, was just to use forceful pulse of 20 cc aliquots 4 times a day. But others have put more than one catheter in a cavity, put a Y connector to do continuous flush, just like we did in the old days with drains coming out through the retroperitoneum. And then it's important, if you're going to do continuous lavage, to very carefully measure what goes in, it's got to come out. Okay, if that doesn't match, then you got to be careful that you're putting saline in someplace else. And then you exchange the catheters as needed, frequently. On an average, every 3 to 4 days, to upsize or to reposition them, make sure they're dependent, make sure they're in the actual position, and so the patients go through numerous CT scans. How do we monitor the patients after a drain? Physical exam by far is the most sensitive predictor, just the bedside gestalt of how the patient is doing, following their vital signs, looking for their SIRS to resolve. But studies have shown that monitoring the CRP and the IL-6 is a sensitive way of predicting success. In those patients that ultimately succeed with percutaneous drainage alone, you'll see the CRP start to drop and IL-6 go down. If, on the other hand, it's going up, beware, that patient probably needs more aggressive additional drainage in some way. Then, as you're monitoring the drainage output, be mindful of how the color changes. Initially, this is all brownish, grayish junk. It's going to clear up over time. If all of a sudden it goes back to a fecal appearance, bilious, or has blood, that's a heralding sign that your catheter is eroded into something and warrants further investigation. When do you re-image? After the placement of that first drain, 48 to 72 hours to make sure everything is hunky-dory and going in the direction you want. Or if the patient is not clinically responding. In the Panther study, they used 72 hours as a break point. If the patient was not clinically improving at that time, they got re-imaged and they had additional catheters placed. And then if there's initial clinical improvement followed by deterioration, look for other sites that might need to be drained. When do we remove these catheters? Once the catheter is completely, cavity is completely collapsed by CT scan, the drain amylase has disappeared, there's minimal output, there's no fistulas by, we call it a tubogram or a sinogram, the patient is doing well clinically. Another more conservative thing, if you have a patient lives far away, is maybe just to cap the catheter, stop all irrigation, repeat a CT scan in 5 days to make sure nothing is accumulated in that former catheter bed, and then it can just be pulled. What do you do if the drainage fails? Should we step up immediately to the endoscopic or to a VARDS approach, or can we do something more aggressive? And in that regard, streptokinase through the catheter has been demonstrated to be effective in some patients. This was a very small series from Kandahar, India, but these investigators were so impressed in these 2 patients that responded so quickly to streptokinase into the cavity. They are now undergoing a prospective randomized, double-blinded trial to establish the efficacy. So something to think about in the future. What are the outcomes from percutaneous drainage? The reference here is from a systematic review. I'm not showing it to you because it's kind of outdated now because we have 3 large prospective trials that weren't included in that. But from this retrospective systematic review, sepsis reversal in 2/3 of patients, 15 to 30% of patients develop fistulas. A pancreatic cutaneous or enterocutaneous fistula is the Achilles heel of percutaneous drainage alone, okay? Hemorrhage in 3 to 5%, the majority of which are controlled angiographically. But overall clinical success with catheter drainage alone is anywhere from 35 to 90%, okay? How do we define success in that regard? Some define it as a bridge to that better time to do surgery down the road, and others have defined it as the avoidance of surgery altogether. So you have to be careful of the definitions. Here are some select major series, and the ones in the red are the most recent series, the New England Journal one that Karen showed, and then the most recent one by the Pancreatitis Study Group from the Netherlands, published just this year. And if you look at the percent for infected, okay, the vast majority is for infected wampums, all right? I want to just talk about this particular study because Pat Freeney, who both of us had the opportunity to work with and we learned a lot from, is really considered the father of this, or the brainstorm behind catheter drainage for infected peripancreatic necrosis. And Dr. Freeney started his series at Virginia Mason, but then he moved across town to University of Washington, where Karen and I both got to work with him and learn from him. And it was based upon his results that then led to the VARDS technique. These patients are a combination of patients that were treated at UW and Virginia Mason. And here are basically the results. 34 patients with infected pancreatic necrosis, okay? These were sick patients. They all had failed response to maximum medical therapy. You can see more than half had multiple organ failure. They had high CT severity indices, and 5 even failed endoscopic drainage. And like I reviewed for you, this was what he did when we saw these patients. They basically had chest tubes into the cavities, and we would go by the bedside flushing and irrigating them forcefully. The point of this study is to show, and this is the first study that really emphasized this, these patients had to be monitored very closely, and you can see the average number of catheters were 3 per patient. They were like porcupines. We had some that had 5 or 6 catheters. They were like porcupines, okay? On an average, they had 4 catheter exchanges. They got continuous tubograms and CT scans until the cavities collapsed and disappeared. And again, this was a sick patient population. 74% had their sepsis immediately controlled. Half of those, 46%, were cured completely, okay? But the time it took was almost 3 months. 18 of them, roughly half, had to be operated upon, okay? And note, central necrosis, okay? And 2 for disconnected pancreases. The success of that approach was attributed to aggressive repeat radiology and close follow-up, cooperation between radiology and surgery. And this was, again, before endoscopic drainage came around, so the endoscopists weren't so involved at that time. There were clear indications for failure. That was progressive sepsis, and the trigger for that was only about 9 days after the percutaneous drain went in, or complications that occurred that couldn't be treated angiographically. So if you look at all the studies, if you look at the systematic review, and you look at the last 3 large prospective trials, what does that data show? Basically, a large number of patients can be successfully treated with percutaneous drain alone, without surgical or endoscopic necrosectomy. And you can quibble for the reasons. Why is there such a wide range in difference between some studies and the other? And the main reason is the trigger point for proceeding on to the next step. So in the Panther study, they used 72 hours. If the patient wasn't getting better, they put a second catheter. They waited 72 more hours, and they didn't get better, they went to the step-up surgical approach. So that defined failure or success. They avoided operation 35% of the time. In the most recent Dutch group trial, they used 31 days. So the longer they waited, they had a higher success rate. They had almost 60% or 50% of patients that avoided operation altogether, okay? One of the key observations that was made by Dr. Freeney was that the patients that developed enteric fistulas got better quickly, and 100% of them resolved on their own without operative intervention, okay? And that thought provoked a hypothesis that has subsequently been studied, and the hypothesis was that when there's communication with the internal GI tract, particularly the duodenum or the stomach, that the, whatever it is within the enteric context, acid or whatever, accelerates the liquefaction of the necrosis and provides internal drainage for the necrosis. And so the gastrointestinal group and the IR docs at Virginia Mason embarked upon this new approach, and that was to wait again as long as possible, to place a percutaneous drain, and immediately in the same interventional radiology suite, once the catheter went in, would do an endoscopy and internalize the cavity as well, wherever it was, into the stomach or into the duodenum. So the patient had 2 ways of being drained, percutaneously and endoscopically with pigtails, okay? And if there were multiple areas, they got multiple catheters. So they might have 3 catheters, and they might have transgastric catheters into the collection. Ideally, you pick where you're going to put your enteric stents the closest distance possible to the collection, no farther than 2 centimeters away. And we manage the catheters the same way, flushing, irrigating, et cetera, and then follow the patients closely with CT scan over time. And this just shows the technique. So you can see here, there's a collection in the left side that's amenable to a posterior approach, but there's a central collection that's not accessible unless you use an anterior approach. Those are the ones that really benefit with the transgastric approach. So here you can see the patient already has the percutaneous catheter in, now goes, the endoscopist comes into the same suite using EUS. They leave the catheter in position, they fill the cavity full so they can easily put, you can see a dilating balloon across the stomach wall, they inflate it just like the endoscopic approach, and then they deploy, you can see 2 gastric luminal stents opposed with the percutaneous catheter. And then the same time, the patient gets the feeding J, so they get their early feeding, like Karen said, and then follow them over time, and then using the same criteria when they can get the catheters out. And what they found was the time to be able to get the percutaneous catheter out was accelerated. And the most amazing thing is nobody developed a intro or a pancreatic cutaneous fistula, and been doing it that way for over 10 years. So they've published this many, many times and now have compared this dual modality approach versus the percutaneous drainage approach alone. And what you can see is that when you use a combination of percutaneous and endoscopic, that the number of CAT scans, the number of drain studies, the number of ERCPs all goes down substantially. The length of stay is cut in half. The time you can see no patient got operated on emergently. Nobody had a pseudoaneurysm with that technique. So this combined approach was superior to the percutaneous approach only. And this is the most recent publication, a couple years ago, over 170 patients treated now. You can see that the mortality is low. In fact, this is the lowest published mortality in the world for infected walled-off pancreatic necrosis. No procedure-related mortalities, not a single patient needed an emergent operation or a VARDS approach, okay? No intro or pancreatic cutaneous fistulas. There were some bleeds controlled with angiographic control. There was some recurrences. And then there were a few patients, but very, very few, who needed a delayed operation. I'm talking about a year or 2 later for a disconnected pancreas. So in summary, percutaneous drainage of wampum is highly effective. It's the logical first step in managing septic patients or those who deteriorate despite maximum medical therapy. Timing is everything. And that we have to look at with a grain of salt. That contributes to some of the good results, selection bias, okay? Aggressive catheter management and study is essential. And for those that fail, percutaneous drain is an essential part of the VARDS approach or a dual modality drainage approach. Thank you for your attention.